what does good look like? What does good governance look like? Let's ask Liz Horn and our panel of data pioneers who are joining us now. Liz has built and supported research initiatives with dozens of nonprofit organizations focusing on registries and biobanks. She's an accomplished mentor to many rare disease leaders involved in translational research enterprise. Liz holds a doctorate in molecular pharmacology and cancer therapeutics from University of Buffalo and an MBI from Oregon Health and Science University. Liz will be introducing our speakers, so I welcome Liz to the stage, and I'm going to have her take it away from here. So, come on up.
Great. Well, I wanted to thank everyone for coming back after the break. I wanted to thank everyone that's attending here with us in DC, and I also want to thank everyone who's watching the live screen and participating. And please make sure to start typing in your questions. So what we want to do today is talk about what does good look like. And I have this wonderful panel of 3 really accomplished women and what they're doing in their organizations. So what I'd like to do first is I'm going to have each of them introduce themselves, tell you a little bit about them, and then we'll start talking about what good looks like. So Sonia, would you like to go first?
Sure. My name is Sonia Dumanis. I'm the Senior Director of Innovation at the Epilepsy Foundation. I love my job and my title because when I think about innovation, it's about taking ideas outside the space and bringing them in. And so what I'm going to talk about soon is just about how we've been learning from what we're doing and incorporating it to make our data platforms and how we use data better.
I'm Terry Klein. I am the President and CEO of the National NPS Society. I'm honored to be here and thank Global Genes for being here. We're a long-standing umbrella organization of 45 years that works with 11 different lysosomal storage diseases, and we have one office that serves the country. And my presentation is really going to concentrate on how somehow over the past 36 months we did a deep dive into doing not 1 but 2 data subset, a registry, and both an integration of a CRM.
Hi, I'm Megan O'Boyle, and my official title is Shannon's mom. She has Phelan-McDermott syndrome, which is, as with every other condition in the room, very rare. And I was recruited into this space of data unwillingly about 10 years ago because I lived closer to NIH than the other families. And that is when I met Liz and learned what a registry was, and I've been treading water ever since.
Great. Well, so I wanted to tell you a little bit about how we're going to run this panel. Each of our presenters will probably talk for about 10 minutes or so and tell us about the lessons they've learned. We're going to start with Sonia, and I'll give you the clicker in a moment. And then we're going to leave a lot of time for discussion. So start writing your questions down and feel free to put them on the online app. And here's the information on how to, if you haven't done this, it's not actually an app, it's a website, but go to datadiy.cnf.io.
Thanks. So often when you think about data, we are like, yeah, we want data because the more data is accessible and available, the quicker that data can be converted into value and action. And I think most people would agree with that. With the idea that we're collecting data, we're sharing data, we're creating an ecosystem, we can then get actionable insights from that data and then keep learning. But the reality is we focus a lot on data collection. We don't focus that much on how that data then is going to be shared, both to the person contributing to the data, but also to people outside the community. And we also don't think about the dashboards we might want to visualize after that data is collected. And that's one of my biggest lessons learned as I took a look at all the breadth of the work that the Epilepsy Foundation has been doing. So I by no means want to say that I lead all of these initiatives. I have listened in or participated. There are a few that I lead. But I wanted to go through 5 lessons learned that correspond to these 5 examples. So the Epilepsy Foundation is a proud partner in the Rare Epilepsy Network, which there are many people in the room that are also a part of, and we are facilitating that platform. I personally spearhead the My Seizure Gauge initiative, which is a platform that is collecting wearable and diary information from people impacted by epilepsy. It's an international initiative to create crowdsourcing algorithms for seizure forecasting. The Epilepsy Foundation supports the Human Epilepsy Project, which is a longitudinal observational clinical study in the traditional sense, where people go to sites across the country, are followed up every 6 months, and so forth. We're proud to be co-founding the Epilepsy Learning Healthcare System. We were awarded a grant to help create with clinicians a clinical registry for epilepsy center sites across the country, really focusing on quality improvement. And we're also now in the midst of thinking about EDEN, which is our Epilepsy Data Experiential Network, to really ensure seamless integration across all the different data that we collect, not just from a research perspective, but we have an information and referral system. We have epilepsy.com that gets about 1 million users per month. We also have our INR information referral that gets 20,000 calls, so we can start thinking about data in other places to really think about our strategic planning and how to connect those. So one of the first lessons learned, and this is really out of the Rare Epilepsy Network from the calls that I listen in on, is that when you have a lot of groups together and you want to have stakeholder engagement, if you want to do it right, it takes time. And when you say something once or twice, that's not really engagement. There's a rule of thumb in communications that you're supposed to say something 7 times for someone to hear. And that's only you communicating out. But if you actually want it to be meaningful and make it a viable platform, you really need to think through what's that organizational structure going to be like, how are their voices going to be heard, who is the staff that's dedicated, to really make sure that you're asking good questions and ensure that those insights matter. For the Rare Epilepsy Network, it was a PCORI grant. It was started, we focused a lot on the data collection. We honestly wrote in the grant about dashboards, and it sort of was done, but we didn't spend as much time thinking about the whole component. And so I think there were some growing pains as the Epilepsy Foundation and figuring out what our role is and how to really help facilitate that platform, because everyone in that platform is an equal partner. And so thinking about that was something that was a big lesson learned. For the My Seizure Gauge initiative that I spearhead, big lesson learned was be explicit as possible about what you're sharing. So here, there's a lot of different data types. We have EEG that's being shared, sometimes from the clinic, an implantable clinical system. We have different types of wearables. We have diary data. And so once we awarded our grant, which was going out to an international team, I then said, okay, here's my spreadsheet. Here are all the data that we're saying we're collecting. What platform are you going to use to actually collect this data? What platform are you going to use to share this data, both internally and then also externally? And it could be the same platform. What's your expected time frame for that type of sharing to occur? And I also explicitly asked, what information can you not share? Because setting those expectations up front makes it a lot easier to have the conversation. It's one of the most enjoyable initiatives that I'm working on right now because everyone's very clear about the expectations, but it took a lot of time to get all those data sharing agreements in place. So we awarded the grant in October. It took 6 months for us to get the collaboration research agreement signed, which might seem ridiculous, but that's just the reality. And because with the My Seizure Gauge initiative, we also are leveraging other initiatives like the BRAIN initiative and the RADAR initiative in the EU. It took an additional 3 extra months, so 9 months total, to get those people on board. But now all the agreements are signed, we know what can be shared, and it's working seamlessly, but it takes a lot of time.
So before you go on, how was your spreadsheet received by the people that had to fill it out?
I think they were fine with it. It sort of made them feel a little bit better too, because I also stressed that I am not there to be punitive. If you explain to me why information can't be shared, I can work with you. So for example, I first said, okay, I want 100% of the information collected shared. And one of the researchers said, well, some of the data is going to be trash just because of the nature of the beast. I don't want to put trash up there. And I was like, well, that's a very valid point. And then, for example, he also said, I want to have machine learning algorithms for crowdsourcing, so I want to hold back some of the data so that they can, after they do their training, validate. Again, very fair point. And so it actually, by being very explicit, opened up the conversation and sort of provided that dialogue where we then could work something out.
And there was transparency and expectations, and people knew what to expect. And I think that when you have dialogue with people, people can be really reasonable, but you have to understand where everyone's coming from and what language they're speaking and why certain things are important.
And not everyone on the team is going to be a data person, right? I understand data. I am not a data scientist. So there are things that I just don't know, and to mitigate my expectations. And some of the team leads aren't data scientists. And so it also forced the 3 groups to talk to each other about how they were going to share. And we've spent a lot of time during this process of creating a platform. It's working, and we're now going to be scaling up the data acquisition. So you need to do this, basically.
So it was time well spent.
Yes, it was time very well spent. But ask me in 3 years. No, but it is time well spent. The other big lesson learned is that, and I've alluded to this before, is that data is more than collection. So, we think about how we're going to collect the data, but we also need to think about, okay, once that data is collected, how do we know we trust it? And also, more importantly, how are we going to return those results back? So this is coming out of the Human Epilepsy Project, where we have a great data collection platform. Researchers actually are doing great validation, so they've gotten that trust component. They're starting to see really interesting visualizations of how, for example, medication can impact mood. But there is no way right now for them to give that information to the people that are spending 5 years of their life to go to these clinical sites, and asking for a huge burden. And it was something that just hadn't been thought about in the get-go. And so I really want to stress that when we're talking about what good data looks like, we're talking about a data ecosystem. We're not just talking about the quality of the data that's being collected. Another lesson learned is that you want to think big, but you want to start small, and then you want to quickly test along the way, right? Don't let perfect be the enemy of the good. So right now we are launching our learning healthcare system. We have 6 epilepsy centers that are on board, which is great. And when you start creating your wish list of all the things you want doctors to be collecting, you realize that it's just not practical. You need to narrow your focus and say, okay, what systems work? Let's test it out. Okay, we say we want to do seizure frequency documentation. Well, there's a lot of different ways we can document. We have 6 different sites. They can test 6 different ways. Let's figure out what's working. Let's get on calls. And this really comes out of the learning healthcare system quality improvement theory, which I had never known anything about, called the plan, study, do, act cycles, where you quickly ramp up and you learn a little bit along the way and start improving the process. So when you're thinking about the data you want to collect, you don't need to go for the home run. You can also think about how do you get to first, second, and third base and do check-ins along the way. The other lesson learned is the importance of linking data sets to think about the future of your data with some identifier. So when you're thinking about data that's being collected, you can have individual level data that's either identifiable, so there's a date of birth, could be de-identifiable, so you could then think about that specific individual response for example, that specific diagnosis. There could be population level data, for example, if we're thinking about traffic to epilepsy.com and how they're searching and they're looking. And then thinking about how can I actually link all this data together and doing that mapping. Because right now, as the foundation, we have amazing resources that we're growing. But now we need to sort of take a step back and say, how can we actually create an ecosystem for all those resources to start talking to each other? And for us to do that, we need to make sure that there's a way that we can link them. And so as you are thinking about data and you're thinking about future-proofing that data, thinking about what's that extra question or what are you going to add on that consent to ensure that you might be able to link the data. Because even if we could link the data here, right now as a foundation, we wouldn't do so without creating the appropriate ethics approvals and consent to do so.
And I think that's a really, really important point, that you need to be thinking ahead and you need to put this in your consents up front, like especially if you want to recontact people. You have to make that as part of your initial research protocol. You can't do your research study, say you won't contact people, and then go back to the IRB and say, oh, hey, can we do this? So I think it's really important to think about those things up front, and I think Meg did a really nice job this morning helping us think about some of those important concepts.
Yeah, and it's something that we always think we figured out, and then there's always something that's left out. So those are my big 5 takeaways, that authentic stakeholder engagement right from the get-go, being really explicit about the data sharing, not just from the legalese of the data use agreement, which honestly very few people are probably going to read, but just creating a spreadsheet that you can read is going to be helpful to have that transparent process. Thinking about the return of results, how you're going to create those dashboards, what you actually want those dashboards to say, how you're going to start small and how that scale up is going to work, and then also future-proofing that data through the consent, but also through thinking about what data you can use for linkages. So those are my big 5 takeaways. I could talk about this for a really long time, but I don't want to talk the whole time. So.
Awesome, thank you. And we're also really excited. We'll be hearing from you again later in another panel to talk about how you start to select partners and people to help you do this, because we can't do all of this on our own. But I'd like to turn it over to Terry right now, who's going to tell us about some of the data that they're collecting. And one of the things that I think is really, really unique about the MPS Society is your ability to work with so many diverse groups, so many stakeholder groups under one umbrella, and having everyone play nicely, because that's not an easy task. So we look forward to hearing about your work.
Thank you. I wanted to share with you, first of all, that my background has been in the for-profit world for many years. And so after our 4th child was born, she was diagnosed with mucolipidosis type 3. And so my background has been in engineering, human resources. I was a commercial broker for many years and owned a company, all of which relied on heavy data subsets. The key to the data helped us to identify risks and mitigate risks at many levels. And so we were relying on software programs and analyzing data on a regular basis. Little did I know that those skills would transfer into nonprofit work, where it's more of a soft, touchy feel with families, and also a drive for research to cures. And how do we bridge data in that, and why does it have to exist? What does it really mean? We're a nonprofit that has 17 members, and when I arrived at the National MPS Society in 2009, after I'd been working internationally for 3 years, we had a data system. We did, we had something. It was collecting membership data, it was collecting donor data, and we realized that during the interview for the Global Genes to set me up for a presentation, that we actually underwent 2 revampings, reinventions, integrations. One with our patient healthcare registry system, which I'm going to heavily talk about in this presentation, but I also wanted to not overlook our internal CRM system. And for those with that acronym, it's simply a contact management system is what it is. It's a contact relationship management system.
The R, I never knew what the R stood for.
Yeah, relationship. But first, let me talk about the timeline for our patient registry. I have to give credit to Jill Wood and Jonas Just Begun, because here was a dynamic parent with a son with MPS IIIC who had the vision to put together a patient registry, and we didn't have one. And so back in 2013, it started with MPS IIIC patients, and they had 188 patients. When she came to the National MPS Society and spoke to me and my predecessor, she spoke heavily about how collaboration and combined resources, we can take this registry to where we need it to be for researchers and for industry. And we needed to be able to start collecting the data, and we were all on board. And at that time, it was Patient Crossroads that was the facilitator of this data sharing platform, which is now Invitae. But look at the timeline really quickly. In 2013, that's where we were. In 15, she had 188 MPS III families that were there. In 2016, we began the marketing, the expansion of the launch to Connect MPS. Because of my international background working on a global level with ultra-rare diseases in the glycoprotein storage disease area, I was able to reach out to a number of our global sister foundations to talk about this. In 2017, we offered a Sanfilippo survey extension, and in 2018 and 19, Invitae had the GDPR compliance, which was critical in Europe to be able to have that component. And we now have over 1,275 patients in that registry, and we did that in less than 5 years. I'm going to come back to Connect MPS, but I first want to talk to you about the CRM integration of the National MPS Society. And what does data mean for the nonprofit when you're collecting this information for membership? I told you and I shared with you that we had a database system, and we were collecting addresses. We might have been collecting a child's name, a child's birth, but what were we really doing with it? Were we talking about bone marrow transplants? Were we collecting information that was not HIPAA compliant, but we still needed to collect that data that could be quite relevant for the work that we're doing, whether it's with industry, whether it's in patient ad board meetings that we needed to have. We needed to be able to rely quickly on a subset of data that we could pull forward, and it wasn't working. It was working for gift processing, It was working if you wanted to find an address. It was working if you wanted to mail a piece of material, but there was a shortfall. And I quickly recognized it, but my obstacle was not one necessarily that you'd think I'd have. It was with my board, and it was with my actual team to help them understand that I'm this nerdy extrovert that knew what data meant if we were capturing it. And we have lost many years not capturing this critical data.
So I just want to pause for a moment because I think this is a really important point. We talk a lot about registries, we talk about health data, we talk about data for science to move research forward, but there's really an important component of organizational data. And I think some of the lessons learned about registry data flows back into organizational data collection. And I think that's something, especially, and actually in all organizations, but small organizations, we kind of overlook. We don't spend enough time thinking about it. And you're really highlighting how important that is.
It was important because we also realized we're building a community. In that community that we're building, that community is going to leverage and provide credibility to us as an organization to help us move our patient registry forward. They are working in tandem, but they are critical to one another because we're building out a community within that database. So let's talk about some of the things that happened. First of all, my team didn't jump ship. I thought they might abandon the captain after they went through the integration process. I really did, but they didn't. Thank goodness they didn't. They are the best team in the whole world. We were able to grow our membership from 720 households to over 2,000 households in that short period of time. Over 289% growth. I think we're at 312% growth now. All because the data may have been there, but it wasn't being managed properly. Knowing that these families have new touch points with us for valuable conversations and valuable research and patient ad boards, even if they have lost a child. Those bereaved families have a special place in the mucopolysaccharides and the mucolipidocious population because they have patient stories to share. And we didn't want to lose those families. We have over 30,000 donor records now. Because my background was in development and operations development, I'm a fund development specialist. I needed to understand who that donor was that gave 2 years ago but hasn't given for 2 years, and I need to get on the phone with them. I am a phone person. It is not uncommon for me to spend my Decembers on 500 calls to our membership to find out why they hadn't gave. But our previous database didn't allow me to do this. I needed to be able to build queries to understand the data and manipulate it. And integration is not easy. It's not simple. But when you recognize you have something that might be good, but it needs to be better, the minute you acknowledge that is the first day you're going to make a change for something better. It'll be the first day that you'll make that change because you know the outcomes of a new system are going to exponentially fulfill your mission and help your patient population. We created a singular CRM that captured data in one platform, but it also works on an intermodal level. And I say intermodal, and what I'm saying there is that all of our departments at the National MPS Society are using this platform for their needs. Our social workers that work in the Pathways program, when they go in person to meet with families at the time of diagnosis, they are able to capture their notes on the families within the system. They open up the system and it looks completely different than it does for the development team. Completely different. We didn't have any of that information. Though we delivered family support at the highest level at the National MPS Society, we had no note-taking. When we had a change in the position, it walked out the door with that person. That can never exist. We are a nonprofit entity. I am here stewarding it for a small period of time, and it is our goal to hand it over to the next person and for it to be in a better place than it was, and all along the way fulfilling our mission. This was the important piece of the new integration system. When I was able to deliver a patient advisory board meeting for industry, and it took us 3 to 4 months to put it together, I am proud to say that 2 months ago, we met with a team from Australia, and we put a patient advisory board together in 3.5 weeks, all because of this new system and the notes that were in it and being able to get to our patients quickly. It was unbelievable. So let me jump back to Connect MPS, because this is the patient healthcare registry system that we had joined on with Invitae, that we had joined on a global level because of Jill Wood and Jonas just began in that wonderful conversation she had with us that said, why not? Just do this with us. And we did. We believed, we thought we could get there. And I wanted to show you some of the data that we extrapolate out from our healthcare registry. You see, we're a small, rare disease population. I mentioned 2,000 active households in our country. Out of the 2,000 active households we have in our country, we have about 1,300 patients living with MPS and ML in the United States. And we needed to do more than that. But we also wanted to provide data back to the patients and the families who are putting the information into the system. It is important that they get to see what their work produces. If they take the time to put the information in and they own the information, this is the type of information that they can extrapolate out. And so here's just a group of subsets that helped us navigate the syndromes so that we could understand what was there.
Well, and it's really interesting too because, well, I'm getting that eye thing, so I can't read it all, but I can see that those are the same values and the numbers are different in the different populations.
That's correct.
And what a great way to visualize. And you had mentioned about dashboards and how important dashboards are about what do you want to show, how are you going to show it, how is it going to provide meaning to our researchers, to our families, and I think that's a really good example.
Yeah, it's been very important for all of us. So what are some of my lessons learned? Because I want to talk about that before I share a few important slides regarding the Connect MPS system. We've learned that collaboration and data relevance is similar philosophy among foundations. And when you are too small and you don't know that you have the ability to put a registry together, think outside the box. And what could you do if you joined forces? If you just pick up the phone and start having the conversation, because there may be another group that wants to join forces with you and leverage it all the way. You have to understand the needed outcomes of any data before you begin building that system. What's the unmet need? What are you driving for? What is the goal? What are the questions that need to be asked in the survey? And know right now, as we had just shared a moment ago, that you will go back and proof your system. You will go back in time and make changes, and you should. Research is changing, and therefore your questions should be changing as well. You should be doing frequent audits inside of your registry. Create an easy access for the patient and provide data back to participants. As Megan had mentioned earlier in her presentation, the little steps in, letting them tiptoe into the system and allowing them to back out will not make it feel so intimidating for them. And we needed to be able to create an environment that did that as well. We also learned along the way that you have to market the registry because these families will not come on their own. We do have to provide opportunities of engagement, and we have to provide a real understanding of what that patient data will mean for research and what it will mean for industry and the future of those that are born with these diseases. So you have to take on that marketing component. I mentioned already that you need to be able to audit your registry frequently. You need to know if you're not having researchers and scientists draw on that registry for some reason, why? Why isn't it working? We've worked so hard to put this together. It's okay to acknowledge that it's not working, but you need to find a solution, and you need to find out why they're not being driven to it. Those that are going to be in the registry with us, they had to put their egos aside at the door. There is no place for them. Put them outside the door or don't walk in, because children are losing lives and we do not have time for this.
So how did you articulate that to people? Because I think we get stuck in life because of ego, and it prevents us from collaborating, it prevents scientists from collaborating, it prevents patient groups from collaborating. So how did you articulate that and get people to buy in?
Jill was really good with us.
Okay.
And so she was really good with us, but we also recognize that many of these foundations, and there's 27 global foundations now that are in these ultra-rare diseases that are in the registry with us. And I'll tell you about a few obstacles we have there, but to answer your question, we recognize that these missions of these organizations were not to build registries. Though they had the patient populations, this is not where they had resources. They simply didn't have the resources, and there needed to be a trust component that we're going to go at this together. We're not gonna forget you. We're gonna go at this together, and we're going to see some measurable outcomes and recognize always, at any point, if you are not satisfied with what's taking place, you can back out. You do own your data. Each patient owns their data in this system, and at any time they can put it in, and at any time they can take it out. But look how much further we're going to go together if we just go together. The idea of these foundations wasting resources to reinvent the wheel and having 15, 20, 30 registries just doesn't make sense to me.
And
it doesn't
especially
make
if you
sense
have
to me.
the same people in multiple registries, and that's the problem without having a common identifier. And it gets even worse with sample collections. If you look into sample collections and 30% of the people are the same, that's not going to be good data and good science coming out of it.
Yeah. We also recognize as a patient advocacy organization that we wanted to be able to survey our own families. So we're currently working with one of our partners, Cure San Filippo, and do a perinatal study because we need to be looking at perinatal issues regarding our syndromes. And so we're able to actually put together a survey ourselves to be able to reach to these patient populations. And those are important things to know, that it isn't always about the researchers or industries extracting information, but we also have initiatives, we have programs, and we need to get to this information as well. Those collaborative efforts are key. So here's a group of some of the foundations that have come together from around the world. I wanted to put together a couple of quick slides as fast as I can, talking about some of the lessons that were learned for the Connect MPS registry. And this is the recommended short list of data requirements that we had put together. We wanted to be able to recognize that patients own their data. That was important. And so they have PINs in the system that we have. We wanted to be able to start a registry in a system that protects the patient privacy. We wanted them to be able to also collect some of that data themselves. And we wanted them to be able to have custom sets of data subsets and reports that I showed you earlier on the previous slides. We also wanted to be able to contribute common data elements to global and NIH registry initiatives. We wanted to recruit screened participants for clinical trials and possible study opportunities. And we wanted to send educational information in newsletters to those that participate. And so we do put this out in various other platforms with the National MPS Society, and others do from around the world. Here are some participant privacy and security settings that were really important for us. First of all, I don't have the ability to understand this information. It was important for us to build a relationship with a company that could deliver the things that were important to us. I am a nonprofit president and CEO and a mother of a child that does not have a therapy still. We do not have a treatment for my daughter's disease. Time is against us. I don't have time to understand this, but I will find someone that's going to work for us and get us there. And so they understood infrastructures. They understood the Federal Information Security Management Act guidelines. All the things that feel way above what I need to know. I just needed to know how to make a good decision to pick the right company. I also know that we didn't have the resources to do a full-on customization registry. So we were looking for something that already existed that was out there. We need to be able to be compliant with the European and the GDPR. I mentioned this earlier because even to this day, one of the most difficult things that I'm hearing, and I didn't mention before, but I'm also the co-chair of the IMPSN, which is the International MPS Network. I meet with the MPS leaders from around the world. We just left a meeting in Serbia 2 weeks ago where we are taking on large global initiatives and humanitarian programs, as well as newborn screening, access to therapy, many things. But one of the obstacles they're having with the registry with us is that parts of the European sector are not ready to relinquish their patient information and join in. They're almost there, and then they kind of hold back. They're very conservative and they don't want to give up that patient data yet. Some of the patients have gone around them and said, oh, we're joining. And they're joining in on their own, because who are they to control us? And so knowing that the GDPR compliancy exists with the system has now opened the door around the world for these patients to join, regardless of what their MPS Society is doing. The participants control their contact and data sharing information, so they're allowed to put in their preference choices and be able to identify whether or not they want to be contacted by the MPS, be part of a survey. They do have an online consent form that's very important. And then the researchers and the data usually only see the de-identified information unless the request is put forth by the participant. Participants, as I said before, can opt in or opt out. So what are the benefits to the patients and the families? They can take surveys. They have opportunities to participate in research surveys without going to clinic. It's mobile responsive site. The option to receive the relevant news and research information. They set and change contact sharing preferences at any time that they need to. They can download copies of the completed surveys to share with their clinicians at appointments. They easily add dependent family members to their data. And they can easily invite others, friends and extended family, to join into the system. Both of these processes happened over the past 36 months. I'm not going to say that it has been easy. Our mission is to support families and to support research. But when I was able to have a forward-thinking board and a team that was energized to know that the data will absolutely help us support our families and help us support the research, then they were all in. And we decided if we're going to go at the same time. And so we ran each of these changes in tandem with each other. We are exponentially beginning to see how much time we have been saving by collapsing the 12 programs we had to run the National MPS Society into one. Our communications, our development, our family support, our surveys are now all coming from one integrated CRM system that was across 12 systems before, and it's all in the same system.
So you talked about communication with your team and your board, and you've been talking about communication with researchers and getting everyone on the same page. Do you have anything to add about how important communication is?
It's so important. I mean, communication. I think that it's important not just to understand the objectives. I think it's important to understand, there's so many different stakeholders and they come to this with different ideas in mind. And if you don't talk about it, there are misconceptions that keep growing. And a lot of times the friction that results is because of those misconceptions. And so just being as transparent and even being blunt about, these are the resources we have, what can we do with these resources, is amazingly helpful, because you'll be surprised that there'll be some people that'll step up that you might not have expected, but they wouldn't have stepped up because they didn't even know that that was an issue.
Yeah, and I think FaceTime's important too, because we do a lot of things remotely. I mean, I've worked from home for over a decade, spend a lot of time by myself with dogs. But, when you actually get to meetings and see people, I think that a lot can be accomplished. So we're just talking so much about data, but there's an underlying organizational behavior piece and communication. So I want to turn it over to Megan. And Terry, that was fantastic. Thank you so much. So Terry talked a lot about getting data in and the kind of data systems. And I've asked Megan to talk about getting data out, because I've been working in this space for a long time, and one of the things that I've seen is that we spend so much time, what should we collect? How should we collect it? What does the questionnaire look like? And then we have this great resource, and this data's in here, in this box, and then it's still in the box. So how do we get it out? How do we get researchers to use it? And so Megan, please introduce yourself and take it away.
I'm Megan, again, Shannon's mom, and Kevin and Sean. Lucky for you, we're going to have a longer Q&A, because I'm not going to talk as much as I usually do, because in Data DIY number 1, which I'm sure all of you live streamed, I gave my whole spiel, and I was in the workbook. So we can just refer back to that and move forward today. So I just also want to go back to one thing. Both those presentations were amazing, but my favorite slide was the one with all the logos, because it screams collaboration. And I think at every part of this, you have to be thinking of collaboration, whether it's with other organizations, whether it's with researchers, pharma, everybody. And you have to think of it early and often. So our goals for data dissemination were to make data more widely available to stakeholders. We started as parents who found out from Genetic Alliance at a meeting once that you need to go build a registry. So we were like, okay, we'll build a registry. Look at who we built it for, though, in parentheses, for researchers and industry. We were caregivers, and we weren't even thinking about what the data would do for us. So I have to admit that that's an embarrassing fact, but it just goes to show you how driven all of us are to get research done. But there's a whole family support aspect to this. And when you're thinking about who you're getting data out to, it's not just to researchers in industry, it's to patients and caregivers. We wanted to be transparent and fair process for review and approval of applicants. I was very fortunate to have Liz as a consultant through this whole process. And if I had to needlepoint something, it would be Liz saying to me, even playing field. You need to be fair. You need to treat everybody the same way. That means there's no favorite researchers. There's no favorite industry partners. You have the same set of rules for everybody. Reviewing applicants for merit, science, ethics, and relevance to our community. The easy part of that is if something has already been funded by, say, the NIH, a lot of people have looked at the science. And in order to get to our review process, they have to be IRB approved. So we're pretty sure the ethics have been reviewed. But only we, as the PMS community, Phelan-McDermid syndrome, if you're wondering why I'm talking about PMS, only we as our community can decide what is of importance to us. And you know, sometimes you don't share with other people for good reasons. Disseminating the data or allowing access to data in a timely manner. You know, if somebody's asking you for something and you have this long, arduous process, they can move on to somebody else who can get them data faster, another disease condition or another organization. Tracking requests for data and access. This is really important. It's important to boards. It's important to donors. It's metrics. You know, how long is it taking to get someone through the review process? Did an article come out about it? You know, what were the outcomes? And it's okay if the outcomes were negative. I would say sharing negative outcomes is one of the most important things in research and is the least often done. Having researchers publish scientific articles about the studies using the data. Despite what John said this morning about publications not causing treatments, it is currently the currency for a lot of these researchers. And so, as Liz said, we want the data to get out and we want the data to get used.
And I think too, when there's an attribution piece, right? So they're using your data and they should be acknowledging the foundation, because let's face it, researchers read papers. And by being in the acknowledgments that, hey, this researcher used our data to do X, gets other researchers excited to use the data as well.
Yes, Ron Bartek from Friedreich's Ataxia once said to me, registries are like growing low-hanging fruit. We are making something really available, make it really easy for them to just grab it and analyze it. So we have a process, a governance process. Again, confession time, not something we were thinking about when we were building a registry. We got to collect the data. We got to give it to the researchers. We weren't thinking about what data was going to go, who was going to get it, and what they were allowed to do with it. And that's why you're all here today, is to learn how important, albeit boring, those processes might be.
It's not boring. This is fun.
Yes, governance is so much fun, but it's so important, and you have to think of it in the beginning. It's really difficult to go back and decide these things. So a researcher may want data from our registry, or they may want to recruit, and we have contact information for almost 70% of our families in the world. So we are the best place to go for recruitment. And whether that's for over-the-phone study or a clinical trial. So they have an application process. It's online. It's very simple. They go through. They fill out some questions. It's not arduous. And our registry coordinator, who happens to be a genetic counselor, handles that. And in the early days, that was me, the registry coordinator, but we are fortunate enough now to have staff. Another thing you need to think about early on. Then the applicants are reviewed by an internal team, and currently that is a board of parents. We're not scientists, we're not researchers, but we know what our children have, we know what we are capable of doing as caregivers, and what would be considered a ridiculous request. So it's really important that you have stakeholders in the review process. And sometimes people ask us really great questions for something that they want to do, but the fact is we may not be collecting the data. So let's not put them through the whole process. Ethics, as I said, is pretty straightforward because we require that they've been through the IRB. It's interesting how often we are the ones that pick up on the fact that the IRB certificate has expired and they need to go back and renew it. And I think they're always kind of surprised that we pick that up. I don't think anybody means to have expired IRBs, it just happens. And the relevance to our community. You know, if somebody were to be doing a study that we just did not think was important to our families, we are not going to put our families who, frankly, don't have time for 3 meals a day and a shower to participate in a study. Then there's a signing of the agreement, and it's important that we understand the data sharing and what the researchers are agreeing to, and don't reinvent any of this. All of this exists, and there's good and bad models, and you just need to ask around. So if approved, the researcher enters into a data agreement. All the records are maintained by the foundation. The researchers will return the data to our registry, to our foundation, in 2 forms, a scientific summary and a layperson summary. Whether they get it published in Nature or Cell is up to them, but by God, our families deserve to have some feedback in terms of what was found. And that, as Liz said, we need to be acknowledged in publications, because that's how other researchers are going to find out that we have this gold mine of information. It is the largest collection of data on this disease in the world, and this is where they should be getting it from, not small, 5-person studies at certain institutions. And then dissemination is data provided to the researcher by us, and everything is de-identified. Of course, there is, if something needs to be identified, then families can be consented individually.
And then secure file transfer, that's another thing that's really important. I'm going to talk a little bit about that later, but remember, you have data, and if you're moving data around, you need to be really thoughtful about what that means and how you're doing it.
Right. And we were very fortunate to receive a PCORI award in 2013, and we were able to build something called the PMS Data Network. It is an extension of our registry, and it allows for real-time data access and analysis. It's a very cool tool. And it again, is low-hanging fruit for researchers. They can go in, and they're not just getting a spreadsheet of data. They're getting a way to drag and drop and have analysis done right there in real time. So that is the shirt that I no longer wear in public, because my son said I embarrass them. Actually, I do. They don't live at home anymore. But I think the best part is always the Q&A. So.
And I think, go one more. Yeah, and
Oh,
Shannon.
and there's my boss.
Yeah. So we want to open it up to questions if we're ready, but I wanted to ask the panel, do you have any questions of each other? Those are all really fantastic conversations.
So what I think is really interesting, what you implied with your registry, is that not only are you collecting information, but researchers can also recontact people for their own surveys. Did I understand that correctly? Or
So, for instance, if I qualify for a study, so a research we would review them and we would approve them. And then we would reach out to the families through the registry. So if the study is about seizures, if you answered no to seizures, you're not going to be contacted for this study. So we have targeted ways we can, contact people according to their genetics, their zip code, their symptoms, whatever. And then once we contact those families, they choose to enter into an agreement with the researcher. And then they enter into an informed consent and work with the researcher directly. But we never give out contact information to researchers.
Yeah, and I guess that was your answer, but I wanted to clarify that point because I think that who has the key data is important when you're thinking about governance, but also thinking about how you can still create a flexible system to allow different people to interact. And that's sort of that perfect FaceTime where everyone comes into a room, rolls up their sleeves and says, okay, in a perfect world, how is this going to work to map out that strategy? And then I guess for you, one thing I was really impressed with San Filipino is that it's all across the world, so I'm curious about language and sort of were there language barriers or how you address that as you're doing that global collaboration and getting people?
Yeah, our site does have translations, and so we do have translations, and I don't want to misspeak which ones they are, but I believe we're translated in 5 different languages currently. We're looking at others. So that's how we're looking at it right now. So we have a translational site.
Yeah.
So,
and I guess
key.
my point to that is also thinking about this is expensive. We're small, but luckily there could be translation capabilities. But as you think about where you go and why you're growing, thinking about those costs is going to be really important too.
Megan has a comment on that translation.
Just a note to add that in the informed consent, elements of informed consent that SAGE has just published, we added a section about expanding your study internationally and on a guide on translation. So just part of the free resource for you.
Great.
Should have known Megan had it covered.
Yes, let's open the questions up.
Okay, so we have a few online, and this can go to all of you. What kind of data do you return to the community, and in what format?
In our situation, almost every question, and we have 300, which is about 275 more than I was told to have. For most questions, after they finish the survey, they can click on the caregiver who's entered the information can click on any question, and they will get a pie chart or a bar chart showing aggregate data, how their answer compared to this study. That means, as John outlined earlier this morning, they didn't need to wait for years for researchers to get the data, analyze the data, publish the data, and then have to buy it back and have to read a PubMed, which they probably don't want to do. So that's like real-time data return. So that's my answer.
Ditto to the same. And just wanted to add in there that patient engagement is critical, and we're in a society where things are so instantaneous, and you're working in this fast speed mode of communication that didn't exist 10 years ago, 20 and 30 years ago. And so being able to provide the patient information right back to them is absolutely key, because they're truly seeing the fruits of the efforts they put in. And so we want them to have access to all of it.
And sorry, they're also leveraging that data in IEP meetings to get services for their
Yes.
children.
Oh,
They're
yes.
leveraging it with primary care physicians to get referrals for specialists.
Yes.
And we teach them how to leverage that data.
And
Yes.
that wasn't something you even thought was going to be valuable in your registry, right?
No.
No.
And we weren't thinking about it.
We didn't think about it, but because our social workers work through Pathways, meeting with our families on a regular basis and working with IEPs, honestly, I feel that in the past couple of years, I'm astounded at the amount of calls we're receiving from public school systems regarding IEP meetings and the amount of work that we're going through to be able to provide support letters so families aren't deported back to countries because they're here to be here on these therapies. It's a changing ecosystem, and this data has absolutely raised the credibility of. I cannot get my support letter any better than what I thought I could, and that data has actually made its way into the support system in front of a judicial system, so a family's not being deported back to another country. So thank you for bringing that up.
Yes, Sonia, anything to add?
I think you guys, kudos to both of you for the amazing work that you're doing. And I think that it also highlights the importance as you're thinking about process, those user feedback pathways, you know, and as you said, you have to audit, not just audit in terms of the data quality and security, but auditing in terms of, and this was alluded to in both talks, you know, are you finding this information useful? How are you using this information? You know, I now start thinking about for research studies, you know, when someone participates in a research study, I say, why did you volunteer? Because I used to assume that I knew why they were volunteering, and those answers can always be surprising to you, and it's the same for the registries as well, and I think that was a really good comment from online.
Yeah, it was.
Can I get in one more? You talked about marketing the registry to your community. I think this may have been Terry, but you can all answer it. What messages do you find are effective?
When I have a large group of people together at a family conference, the messages that can be effective are sometimes visual. Be able to provide a platform right there and then for them to access the registry to get online. We have captured a number of our families just by coming to family conferences and having a booth set up. I'm going to just say it because I can. We have had incentives too. So we've done lottery drawings. I was thrilled to see that we sent 2 beautiful gift cards to a family in New Zealand who had 2 children affected by an ultra-rare disease that participated in the registry, and we did a lottery draw and they won the gift certificates and they were thrilled with it. So we've offered incentives too. We have our registry at the bottom of our tagline. So underneath my Terry Klein name and my phone numbers, I have the registry button there, so that anywhere I can have it forefront, our quarterly newsletters, our monthly e-blasts, it will be there on the website, of course.
And we, again, did not think to do this in the beginning. We just thought, you know, everybody will understand the importance of the registry. And they did, but they don't have a lot of time, and they were overwhelmed. And so incentives have been great. And of course, they have to be reasonable, or your IRB won't approve them. But we have a for the most part, non-speaking community, and everybody wants an iPad, and these kids often destroy them. So a lottery for an iPad made our registration just skyrocket. It was
With the protective case.
Yes.
Yeah, with the OtterBox.
But you know, we were getting great participation, but then I realized that people weren't going back in, and finally I realized that we weren't giving the value statement. What is the value to the family? You know, we've been selling the value to research, and I finally just said, help us, help the researchers, help your child. This is not something that's not tangible. This is tangible. And also just explaining that this data can be used in IP meetings or in medical settings. Show them how to use the data. And returning the data, I think, is invaluable. It's better than any Amazon card you can give anybody. So if you haven't built a registry yet, I would recommend that.
Also, one other thing I want to add to that was that she mentioned the researchers. We work with our researchers. If our researchers believe in what we're doing, we ask them to say it. We ask them to promote it. When we have our conferences and we have our scientific and family conferences running in tandem, our researchers will speak to the registry and how valuable that information's been to them. And so it isn't just about us, it's about the researchers actually sharing the message as well.
We have a comment back here.
Yes, thank you. I was told to stand up, but not to interrupt your comments. Thank you so much. My question is, we're very early in our disease community. Disease was only discovered 5 years ago. My question is, right now we have 2 existing registries, and for me as a community representative, I wanted to assess exactly what those registries entailed and getting a lot of pushback from both registries because one is privately owned and the other is in Europe, trying to get information collected to assess our needs, if it meets our needs, to move research forward. Any suggestions as to how to access, even trying to get what are the consent forms? Can I get a copy of them? Can I review it? How can we access that information? Just basic things that I would think would be accessible to a patient community. Also, when IRB reviews are used, I guess speaking towards Meg's point earlier, used as, well, you know, IRB protects you. I have been told, well, we have this review process to protect information going out. You as a patient advocate aren't qualified to review this information. And so leave it to us, the scientific community. How do I, as a parent and a patient advocate, push research forward? Loaded question, because my time frame is obviously much different than a research time frame. And all due respect to researchers, I need them on my team, but we keep on speaking of collaboration, cooperation, let's go together, but there's that push and pull. I want them on my team, but I can't bring them to the table if they're not willing to come to the table. Any suggestions?
So I have a question. Have any of you, to build on that, have any of you worked with a really challenging researcher and you had to get that researcher on your team and you had to kind of reshape that paternalistic relationship? Do you have any experience with that, or?
We had a delightful researcher, and they weren't difficult, but they literally said to me in 2011, I think it's so great that you're doing this. And it was almost like she was saying, this is so cute. But you're parents, you're not clinicians. And I said, yeah, I know, but clinicians see one kid with this disease, and we as a foundation need to get the data from everybody. So we're just gonna go ahead and do it, and if it's not good enough, then you don't need to use it. And that clinician was one of the first to say when the data was available, so what do I need to do to get the data? I'm like, yeah, it's suddenly very valuable data. But I had to explain, and I don't think this is as much of an issue anymore now, that parent or patients entered data is just as valuable as clinician entered data, and often more so. And I've given the spiel 1,000 times. You can see it probably in the last presentation of why I, as a parent entering data on my computer at home, is much more accurate than me in a clinician's office with the clock ticking and a child who's trying to elope than the data I'm going to give a clinician who's going to enter it. So to answer your question, we haven't had any horrible players. I am a big everybody needs to collaborate, but I kind of think you need to take your toys and leave the sandbox and start your own, frankly, if you're having
and we
that
can
much
talk about
pushback.
this offline. I mean, I think this is a good come up to us after the break, because sometimes you are going to run into difficult people that don't want to move this forward. But I think, by and large, researchers and physicians are in a system that incentivizes different things, and many of them are coming along, although sometimes they're trapped by the system, but some of them just won't. And you might just have to cut bait, but we can talk about that later. I think we're running towards the end, and I feel the hook that's going to pull us off. And we're standing between lunch.
Definitely.
Yes.
No. So, well, thank you, everybody. Phenomenal panel. And yes, so we are going to take a break for lunch. For those at home, take a break as well. We'll be back at 1 p.m. Eastern Time, where we get into this afternoon. It's going to be action-packed because we're going to get into planning mode. What does your plan start to look like? And Liz is going to lead us through that. That's the what, then the why. Steve Roberts, Chief Scientific Officer of Tuberous Sclerosis Alliance, is going to be here to show how that data turns into something that the FDA values and wants to see. And then we're going to close out with vendor and platform discussions and strategic decision making. So thank you again.